honestly, in lung cancer, you can't do that. You don't have that many patients who are out at 10, 20 years with metastatic disease. And we also have the luxury that they all get the same therapy. Everyone gets platinum. No one's going to be cured if they're not getting platinum when they have metastatic disease, no one other than the 5% from the earlier days. We are looking at what we call genomic susceptibility to late complications of therapy. We know what those complications are. They can be neuropathy with numbness and tingling in the hands and the feet, including painful numbness and tingling, which can prevent people from maintaining a normal occupation. Decreased hearing and ringing in the ears. Ringing in the ears might seem trivial, but if you have it, it's not. It's just this constant ringing that's there all the time is just extremely annoying. Doesn't shorten your life, but it's very annoying. And then the more serious late complications are second malignancies, such as leukemia, and also cardiovascular disease. And the whole gamut of cardiovascular disease, which include blood clots, myocardial infarctions or heart attacks, elevated blood pressure, elevated cholesterol, and all things that can lead to it. We also look at fertility issues. When we cure testis cancer patients, 60% of the time the sperm count returns to normal, but 40% of the time it's permanently low and they can't father a child, which is why we offer sperm banking prior to doing therapy. So we knew all that in the 1980s and 1990s. So what we're looking at now is not to catalog how many people have these complications. We know about them, but can we do something about it? Can we identify people up front who are more likely to have the problems by having some genome-wide associated studies, just GWAS, just looking at what is in their blood that can predispose to getting these? And more importantly, can we do something to prevent it? And finding the incidence is the easy part. Doing something about it, or finding a particular mutation is much harder. Finding then something that can block that mutation is the dream. But I look back at nausea and vomiting. A very simple blood study found that a particular chemical was released after platinum, and a rational drug was designed, and we just made such a major difference. So if we can prevent these problems from happening, that would be great. But even if we can't, it's like BRCA1, BRCA2 in breast cancer. If you know you have a susceptibility gene with a family history of breast cancer and ovarian cancer, you can get more frequent mammograms. You can make the difficult decision about having prophylactic mastectomy. So at least if we know things, and it's very important for all of our patients to pursue a healthy lifestyle. Don't smoke, don't be overweight, don't exercise regularly, have your lipids checked with cholesterol, have your blood pressure checked, but even more so if someone has a susceptibility gene, that they're at risk for getting these particular type of problems. And then the other thing that we've looked at for some time, even before we recruited Lois Travis, is the role of low testosterone. And I would tell you that we were among the first to be looking at this, and a lot of places thought it was trivial, and it's not. A lot of men would complain of fatigue and erectile dysfunction, and it would sort of be, oh, stop complaining, you're cured of your cancer, And the background of that is, well, what are we supposed to do about it? You've been through platinum chemotherapy, and that's just the way it is. Well, not really, because a lot of these problems are related to low testosterone. And so men will complain when they have difficulty having and maintaining an erection and feeling weak and tired, and people will check their testosterone and put them on replacement testosterone. That means that the one remaining testis isn't working overtime enough to produce enough testosterone. But other symptoms of low testosterone include depression, irritability, insomnia, and when women go through menopause, they have hot flashes. Men don't complain of hot flashes when they have low testosterone. They complain of night sweats or increased sweating. So we regularly query our patients about all of those symptoms, not just for quality of life issues, which is extremely important of and by itself, but one of the potential causes of cardiovascular disease as a late complication is chronically low testosterone. Chronically low testosterone can lead to something called metabolic syndrome, which can lead to elevated lipids, problems with glucose regulation, and early cardiovascular disease. So we're not going to not give people platinum, obviously. But if we can identify some of these patients at risk, look at factors like hypogonadism, low serum testosterone, to prevent some of these things from happening. Look at behavior modification, exercise, obesity, and smoking. These are things that we can do to prevent these. And we have a very good program at Indiana University, and we don't discharge our patients after 1 year of follow-up. We make sure that they're being seen by us or someone else, and that they continue to follow a healthy lifestyle. And we like to pat ourselves on the back and think that our patients perhaps have less of these late complications when someone is just tossed aside and say, well, you're cured now, lead your normal life.
Great. I wanted to ask you a couple things about, well, maybe about the aspect of, you mentioned that platinum is used in a wide range of cancers.
Oh, yes, still is.
So is it fair to say that the work that was done on testicular cancer and the effectiveness of platinum there led to then the use in other cancers? Was that the progression?
Absolutely. In fact, when I give lectures to scientists and oncologists, I make the point that just as platinum has saved the lives of hundreds of thousands of men worldwide with testis cancer saved the life of platinum. Because if we go back to the 1970s, when platinum was being used in every disease, again, when a new drug is developed, no one has the intuition that it's going to be a miracle drug in this disease. With a molecular targeted agent, you're looking at a particular disease, but with chemotherapy, it's very non-specific. So if you treat 100 patients with platinum, and 1 or 2 out of 100 are testis cancer, and the rest are kidney, melanoma, bladder cancer, colon cancer, lung cancer, and you see this horrendous toxicity and just a little modicum of benefit, you think that the toxicity greatly outweighs the benefit. And I really, truly do believe that if testis cancer didn't exist, that platinum wouldn't exist. And so here we are 40 plus years later, and it still is first line initial chemotherapy for metastatic disease in 11 different diseases. Drug that is used as first-line therapy in nearly as many diseases as platinum is, and it's had legs 40 years later. It's still true. It's also true that we've gone as far as we can with platinum. We're not going to find a new method of giving platinum, although we are looking at research here at Indiana University for the patients that aren't cured with high-dose platinum on the bone marrow transplant unit. We look at what is a mechanism of developing resistance to platinum, because everyone initially responds to platinum with testis cancer. And so one of my colleagues, Dr. Costa Albany, who's brilliant, is looking at a method called hypomethylation and looking at a new drug that can reverse platinum resistance. And the ideal laboratory to do that in is testis cancer, not lung cancer, because platinum in lung cancer produces remissions that last months. Platinum in testis cancer can cure people. So if we can overcome platinum resistance with something that has a laboratory rationale, and this is a study that he is running here at Indiana University, that can make a major difference in all 11 of these diseases. So although we're not developing new platinums, we're looking at, or new chemotherapy drugs, we're looking at trying to figure out why a patient becomes resistant to a drug when they initially had a spectacular response to it, only to have the cancer come back and not respond subsequently.
Going backward again, and you've touched on this already to some extent, but given the wide range of cancers that platinum ended up being utilized in, going way back to before that was the case.
Right.
Tell me again about why did that drug particularly attract your interest? I mean, was there intuition involved? This is kind of the discovery process, I guess. How did it become
Sure.
uppermost in your mind, I
Yeah.
guess?
So a couple of things. So when you look at chemotherapy drugs in the 1960s, so I was in medical school in the 1960s, and I was in Wichita, Kansas, in the military in the early 1970s. And all cancer drugs were either hormonal therapy, like for breast cancer and prostate cancer, or there were called alkylating agents or antimetabolites or drugs that affected mitosis. So all drugs were very similar. You had just these 4 different mechanisms of action. And then platinum comes along. It's just a totally different drug. And, you kind of romanticize about this unique drug that can be different than any other drug that's out there and looks so promising in animal models. Again, the initial studies were in animal models, which is why I kept that particular article. And when I was in the Air Force, we used to have what are called journal clubs, and we had the rheumatologists, the cardiologists, everyone there, And so I had picked that particular article to discuss and kept it with me, but it hadn't yet been done in humans. And then when the first study came out in humans, in testis cancer, because studies had come out with platinum and other diseases, it was interesting. And one of the other things, and this was a naive misconception on my part, but the reason why platinum causes 40% of the patients not to be able to father a child, to cause infertility, is because it causes some atrophy of the remaining testis. And I thought, well, gee, if a drug causes atrophy of the testis, maybe it can do something for testis cancer. Well, of course, now we know that many drugs cause testicular atrophy. It has nothing to do with its effectiveness of testis cancer. And as far as intuition, there's a science to intuition. And in fact, we're studying intuition in a very different aspect with our urology colleagues, especially